Hello, my name is Dr. Joe Hanson, and I'm from Med School Tutors, where I've worked as an individual tutor for medical and board exams for over 5 years. Today, I'm here to help you best utilize UWorld's new question bank geared towards physician assistant students and those preparing to take the Physician Assistant National Certifying Exam. To that end, we at Med School Tutors know that there's more to understanding a question than simply learning the correct answer. And so today, I've selected a practice question from UWorld's free online trial version for us to work through together. Without further ado, let's go ahead and dive in. The first thing we're going to do is to take a look at the bottom of the vignette and read the actual question that they're asking. Here they ask, which of the following is the next best step in management of this patient? Now from this, we can already tell that we're likely looking at a second order question. What I mean by that is that we will first have to identify the diagnosis for this patient and then determine the proper intervention for that diagnosis. Two things we're going to have to do here. Now, in other cases, we may be able to identify which organ system we're looking at and maybe narrow down what this question wants by reading the actual question first. No such luck here. All we can identify is that it's a management-based question. So we go back to the top of the question and read from the start. A 42-year-old man is brought to the emergency department due to 4 hours of chest pain and shortness of breath. So you'll notice that I'm utilizing one of our most important facets here on the question bank, which is the highlighting tool. This is going to be incredibly important to use judiciously in order to bring out important clinical information that we will refer to later. In this particular case, I've highlighted demographics, 42-year-old man, chief complaint, chest pain and shortness of breath, and duration of chief complaint, 4 hours. With this information, we can tell we've got a guy coming in with acute onset chest pain, which we know is usually going to be related to cardiac pathology. In particular, cardiac pathologies that could lead to acute onset chest pain include myocardial infarction and myocardial ischemia, aortic dissection, and pericarditis. In addition, we should pay attention to that shortness of breath and remember that this could also be the other major organ system related to shortness of breath, which is the pulmonary system. So acute onset chest pain related to the pulmonary system could be something along the lines of a pulmonary embolus or tension pneumothorax. So now we've constructed a relatively wide differential merely on the basis of the very first presenting sentence of the vignette. That might not seem too helpful initially, but from here we will winnow down that wide differential into a more narrow differential based on new information that's presented going forward. So we've got a big list of possibilities and we'll have fewer and fewer as we read more information going forward. They then tell us that he has not had similar symptoms before and that he returned to the United States from a business trip to Paris a week ago. This is an important piece of information first because they rarely tell us about travel history unless it's relevant. And second, a business trip to Paris likely means that this patient was on a long plane flight, and a long plane flight is a good time to develop venous stasis, which leads to the development of deep venous thromboses, which then could embolize up to the lungs and cause a pulmonary embolus to occur. So we have a piece of information that points directly at one of our differential diagnoses, pulmonary embolus. That being said, we cannot choose that as our answer just yet. There's a lot more information for us to read through first. So we'll continue to read through the vignette and see if there's anything else that becomes more likely as we go. So they tell us he thinks that his symptoms are due to an upper respiratory tract infection, which he suspects he contracted from recirculated air on the plane. Now, not to dismiss patient concerns or patient intuition, however, there's no objective data in here. This is merely the patient's own account of his belief of what's happening, and that doesn't actually help us to make a diagnosis. So I will not highlight anything in here because it will not help us to create a better answer for this patient. They then tell us the patient takes no medications and does not use alcohol or illicit drugs. Once again, there are no pertinent positives here. There's nothing to point me in a specific direction, so I'll leave that unhighlighted as well. The next sentence, however, tells us that he has a 20-pack year smoking history, and this is a pertinent positive and relevant in particular because a long smoking history increases the risk of atherosclerosis, and atherosclerosis is the underlying lesion that leads to the development of myocardial ischemia and myocardial infarctions. Not to mention, smoking also increases hypercoagulability risk, which might also contribute to the development of a DVT and PE like we had suspected before. Nevertheless, we have two things that are now competing for our attention in terms of the wide differential we had constructed before, myocardial infarction versus pulmonary embolus. We go on to find that his blood pressure is elevated at 152/99 millimeters of mercury, and his pulse is tachycardic at 92 per minute. I will highlight both of these both because it's numerical information. I probably would highlight them even if they were normal values just to make them pop out to me later on. But these are also abnormal values that are definitely worth highlighting in this case, hypertension and tachycardia. They then tell us his BMI, which is 32 kilograms per meter squared. And we might not initially know whether or not that's an abnormal value. So what we can do is take a look at the lab values down at the bottom left corner of the page, and we can use those lab values to look up the normal range for body mass index, which is 18.5 to 24.9. We can then conclude this is an elevated BMI. This patient is in the obese range. This doesn't really help us to narrow our diagnosis any further. Obesity would help to contribute to both hypercoagulability and a DVT, as well as myocardial infarction and atherosclerosis. So we can't really gain anything new from that. So it just helps to further solidify our top two differentials. Finally, we move on to our last piece of information that they give us, which is the ECG shown in this hyperlinked exhibit. So we'll click on that and pop up our image of the EKG that they give us. Now, clinically, there is a lot of information to pull from a full 12-lead EKG. Classically, the pintab of things that we'll be looking for in a full 12-lead EKG would include rate, rhythm, axis, intervals, and morphology. Now, we are limited for time as we're answering these questions. On average, we should spend about 90 seconds per question, and we certainly don't have time for a thorough reading of an EKG. So rather than going through all 5 of these individual components, we should try to take our differential diagnosis and apply it to the EKG. Now, for a pulmonary embolus, the typical finding that you could identify on an EKG would be what's called an S1Q3T3, which is a little esoteric. On the other hand, one of the key diagnostic findings for a myocardial infarction are ST segment elevations on the EKG. So what we can do is specifically look for morphological changes on the EKG, attempting to identify any ST segment elevations that we see here. And indeed, as we scan through this, we can see that lead V2 and lead V3 show very clear ST segment elevations. With that, we've pretty much satisfied our search if we have ST segment elevations in specific leads and not in every single lead. And we already suspected this person might have a myocardial infarction. This should confirm our suspicion that this is most likely an MI over the other likelihood, which was the PE, which would not show ST segment elevations on EKG. So we created our diagnosis. And now we can look back to the question in the highlights to see if any of the pieces of information we had previously thought relevant contradict this choice. 42-year-old man, 4 hours of chest pain, shortness of breath, sounds right for an MI. Business trip to Paris a week ago doesn't help us to make the diagnosis of MI, but it also doesn't rule it out or exclude it. And the 20-pack year smoking history, hypertension, tachycardia, and elevated BMI are all consistent with this answer as well. Because our highlighted pertinent information from this question does not contradict the diagnosis we made, we can feel relatively solid that this is probably the right answer for this patient. However, the question isn't simply asking what the diagnosis is, it's asking for the next best step in management. So now we can look at the answer choices and begin to rule out those that are completely incorrect and totally impossible for myocardial infarction management. Looking through these answer choices, answer choice A says cardiac enzymes and serial ECGs. Well, this is something that would be done when somebody has a myocardial infarction. It would be difficult for me to say that we would never do this for an MI, so I'm probably not going to cross it out. However, if we look down at answer choice B, CT angiography of the chest, I would simply not do this for myocardial infarction. This is not indicated. This is more for an aortic dissection. And so as a result, I can use the strikeout tool because I am certain that I will not choose that answer. Going further, exercise ECG stress testing for answer choice C is also completely impossible. While it is related to cardiac ischemia, we would usually use an exercise stress test in order to determine whether somebody has cardiac ischemia as a screening measure. This would be done way before the patient develops actual pathology and symptoms of a myocardial infarction and would be inappropriate in this setting. You can intuitively identify that putting a patient on a treadmill when they have a myocardial infarction right now might be inappropriate. The next answer choice, Nsaids, non-steroidal anti-inflammatory agents, and colchicine actually are the therapy for pericarditis. Now, that's not our diagnosis here, so we can rule that out. Furthermore, we also know that pericarditis usually shows us ST elevations in every single lead on the EKG. So that might make us think, okay, let's look back at the EKG and identify, was this pericarditis? Did we miss that? And no, we still only have ST segment elevations in limited leads, which means myocardial infarction remains our best answer choice. Finally, we're left with percutaneous coronary intervention, which is the mechanism by which we would do balloon angioplasty and stent placement, which are both good therapies for myocardial infarction. Notice that we variegated our answers into 3 categories now. We have the answers that are totally impossible, which we've struck it out. We have answers that are possible, answer choices A and E, and now we're going to select the answer that we think is best. And given that we need to provide management to this patient in order to help improve their clinical status, the most important thing to do now is percutaneous coronary intervention. You'll notice that when they give us the percentage of students that chose each answer, the two answers that we had available were the two most likely chosen by other medical students. This is a good goal to strive for. Strike out the answer choices that were not chosen by others and keep open the answer choices that were actually chosen by other students, because this demonstrates that our thinking was in line with our peers. So now that we've answered our question correctly here, we're going to take a look down at the explanation. The explanation to the question is going to show us what we should have found in the EKG, which shows us that we do have ST segment elevations in multiple leads. In addition, they have a nice paragraph describing the pathology for this patient. You should thoroughly read through this paragraph and then move on to read through each of the incorrect answer choices and why they were wrong. In particular, for Nsaids and pericarditis, they showed us that they have another diagram which shows diffuse ST elevations throughout the entire EKG to demonstrate why that was not the correct answer here, because we didn't have diffuse ST elevations. Finally, we get down to the educational objective, which summarizes the entire problem for us. Now, one of the biggest recommendations I can make when it comes to evaluating the explanation is, first, read the entire thing thoroughly, but then if you intend to take notes, try to take limited notes on all of this information, meaning that you should take one key idea from this explanation and write that down in your notes. This is the process called creating a UWorld journal, where you put a discrete fact from every single question into an organized notebook, Word document, Excel sheet, etc. The actual format in which you take the notes is unimportant, but the limited nature of the notes is important because there are thousands of questions in UWorld, and writing down even one discrete fact from every question is going to leave you with thousands of facts, and it's very difficult to evaluate if you allow those notes to proliferate. So in this particular case, you might use the educational objective to guide you in determining the one key fact you want to pull away from this question. However, if you feel fairly confident about ST segment elevations, but you weren't especially confident about, say, pericarditis and its finding, you might instead choose the one thing for you to remember from this question to be the findings on EKG that you get with pericarditis, so we can recognize that for future problems. As you make your way through and write down a key fact from every question in UWorld, you can then organize these based on specialty or subsystem, and then use these as a basis for flashcards or spaced repetition review in the future. Now that we made it down to the bottom of the question, we've learned everything we can from it, we can move on to the next one. I appreciate you guys taking the time to listen to me today. Good luck on all of your exams. And from Med School Tutors, we'll see you guys on the wards.